Codox-M IVAC has been a intensive chemotherapy regimen used for aggressive B-cell non-Hodgkin lymphomas. It was developed for Burkitt lymphoma many years ago by the pediatric group at the National Cancer Institute, and was originally a pediatric protocol, but it's been used for adult Burkitt lymphoma and other aggressive B-cell non-Hodgkin lymphomas in adults as well, but is associated with a high cure rate, but with considerable toxicity. So the NCCN guidelines actually include the use of IVAC with rituximab as a standalone for relapsed and refractory Burkitt lymphoma and other aggressive non-Hodgkin lymphomas, really based on really almost no data. There was only a small, the only publication we're aware of was a small retrospective study of second-line IVAC without rituximab in relapsed refractory large cell, diffuse large B-cell lymphoma and T-cell lymphoma, which showed a lot of toxicity. So we've been using this for a long time at Memorial Hospital with absent data as a option for treating relapsed refractory aggressive B-cell lymphoma. We looked at our experience between 2004 and 2019. We looked at objective response rate, progression-free and overall survival, and hematologic and key non-hematologic toxicities. So we had 54 patients. The median age was 51. 35% were female, the rest males. The diagnoses were Burkitt lymphoma, diffuse large B-cell lymphoma, and other. So 76% aggressive diffuse large B-cell lymphoma, 6% Burkitt lymphoma, and other aggressive lymphomas, 19%. 85% of patients were stage 3 and 4, and although we had no primary CNS lymphomas, we had CNS involvement at the start of IVAC in 30% of patients with systemic lymphoma. We used primary G-CSF prophylaxis in 93% of the patients. 94% received antimicrobial prophylaxis of various types. The median follow-up time was 22 months. The overall response rate was 48% with 15% complete responders. 31% of patients were refractory. The median progression-free survival was 3.1 months, and the 3-month progression-free survival was 50%. The median overall survival was 4.9 months, and the 3-month overall survival was 65%, and these were rather poor results. We found in a Cox regression model that factors significant for progression-free survival were no CNS involvement. Some patients were treated with rituximab plus IVAC, others not. Rituximab was a favorable risk factor, and patients who received at least 3 cycles did better than those who didn't. For overall survival, rituximab again, administration was important, receiving 3 or more cycles, and response. Toxicity was considerable. Grade 4 anemia was seen in grade 3 and 4 anemia was seen in 93% of patients. Grade 4 neutropenia in 89% of patients. Grade 4 thrombocytopenia in all patients, 100% of patients. AST, ALT elevations in 1%, neurotoxicity 1.9%. Febrile neutropenia was seen in 65%, infections in 44%, and there was a 15% treatment-related mortality, mainly due to bleeding and infection. So the hematologic toxicity grade and incidence did not vary by the number of cycles received. Febrile neutropenia occurred in 47% of cycles and did not vary with the number of cycles received. The use of GCSF or microbial prophylaxis, neither one seemed to affect this. The type of antimicrobial prophylaxis also did not seem to make a difference. So in conclusion, we found that IVAC plus or minus rituximab yielded relatively frequent but transient responses in relapsed refractory aggressive B-cell lymphomas. The strongest predictor of survival was subsequent going on to transplant, suggesting that bridge to transplant is a niche for this as bridging therapy. Profound toxicity, regardless of degree of exposure or prophylactic measures, risk of treatment-related mortality really warrants strong consideration of other options for most patients. And we are not enthusiastic about its use, only with the exception of a very small number of young, fit patients where it can be a possible bridge to transplant.